All right, get ready to dive deep, everybody. This one's for all you nursing students out there, especially those of you in your first critical care class. Buckle up, because we're tackling some serious respiratory conditions today.
Absolutely. We're here to break down those must-know concepts, the kind of things you'll need to know like the back of your hand to care for patients with these conditions.
Speaking of conditions, I've been feeling a little under the weather myself lately. Cough, cough.
Oh, are you all right?
Yeah, just a tickle in my throat. Probably all those late night study sessions catching up to me. Cough.
Hopefully nothing too serious.
I think it's just a cold. But hey, it's a good reminder, right? Respiratory issues can sneak up on anybody.
That's for sure.
And when you're in critical care, well, you got to be ready for anything. So before we get into the nitty-gritty of specific conditions, let's do a super quick review of, those ABCs of respiratory care.
Yes, the foundation.
Airway, breathing, circulation, and safety. It's like you hear this everywhere in nursing, but especially in critical care. Why are these so important when we're talking about respiratory problems?
Because it's the fundamental priorities in any patient assessment.
Hmm.
Particularly when there's some kind of respiratory compromise involved. You need to ensure that airway is clear, like that's an immediate life threat if it's blocked. And then breathing difficulties, well, those obviously have a direct impact on the respiratory system as a whole. Circulation is about ensuring that whatever oxygen the patient's taking in is actually getting transported throughout the body. And safety. Well, safety is always a top priority in nursing care, right? Especially when your patient's like struggling to breathe. They could be confused, agitated, all sorts of things.
Makes sense. It's like once you've got that clear airway, effective breathing, stable circulation, then you can really zero in on whatever that specific respiratory condition is.
Yeah, like building a house. Gotta have a strong foundation before you can start adding the walls and the roof.
Exactly. And just like a house needs that framework, the respiratory system has its own, super intricate structure. You've got the upper respiratory tract, which like does the initial work of moving, warming, filtering, and humidifying the air we breathe. Starts with the nose and all that.
Right, and ends with the larynx.
Right. And it's involved in, speech and singing and all the funny noises we make. But when we talk about gas exchange, that's where the lower respiratory tract really steps in, right?
Exactly. The lower respiratory tract, that's where the magic happens. Starting with the trachea, branching down to the bronchi, the bronchioles, and then finally those tiny air sacs, the alveoli. That's where the exchange of oxygen for carbon dioxide takes place.
It's wild to think that those tiny little structures are responsible for something so vital. It's like, I don't know, a busy marketplace where oxygen and carbon dioxide are constantly being traded.
And you know what else is being carefully balanced in that marketplace? Acid-base levels.
pH. I remember from like basic nursing classes, the body is super particular about maintaining that narrow pH range. If anything goes off, it's trouble.
Right. And when it comes to respiratory conditions, there are two acid-base imbalances that are especially important. Respiratory acidosis and respiratory alkalosis.
Okay, let's break those down a bit. Respiratory acidosis, that's when the blood becomes too acidic, right? What causes that to happen?
So think about hypoventilation. Maybe the patient isn't breathing deeply enough or frequently enough, or there's an obstruction somewhere in the airway. Whatever the reason, it leads to a buildup of carbon dioxide in the blood, and that makes it more acidic. Conditions like COPD, an overdose that suppresses the respiratory system, or even a really bad asthma attack, those can all lead to respiratory acidosis.
So basically, too much CO2 hanging around in the blood, it throws off that delicate pH balance and makes it more acidic.
Exactly. And then on the other side, we have respiratory alkalosis. This is where the blood becomes too alkaline or basic.
So in this case, too little CO2 in the blood.
Precisely. And this usually happens because of hyperventilation. Think about like a patient who's really anxious and breathing super rapidly, someone with a pulmonary embolism, even a patient on a ventilator that's set to breathe too quickly. They end up blowing off too much CO2, which makes their blood more alkaline.
Okay, I like that. So too much CO2, it's like adding vinegar to the blood, makes it acidic. And too little CO2, it's like adding baking soda, makes it more alkaline.
That's a great way to remember it. And the body, it's pretty smart. It tries to compensate for these imbalances. To really understand what's going on, we look at those lab values, the ones you mentioned earlier, pH, PeCO2, that's the partial pressure of carbon dioxide in arterial blood, and HCO3, which is bicarbonate. It's a buffer that helps regulate pH.
Those lab values. They're like little clues telling us what's happening inside the body, but there's so many combinations. How to keep them straight?
It's all about recognizing the patterns. Let's start with uncompensated imbalances. Here, the pH is abnormal, and either the PaSO2 or the HCO3 is off. but not both. It's a sign the body hasn't kicked in its compensation mechanisms yet.
So, for example, in uncompensated respiratory acidosis, we'd see a low pH, that means acidosis, right? Then a high PaSO2, showing that CO2 buildup, but a normal HCO3, because the body's not compensating yet.
Exactly. Same idea with uncompensated respiratory alkalosis, but in this case, you see a high pH, a low PaSO2, and a normal HCO3.
Got it. So uncompensated means the body's still figuring out what hit it. What about when it starts to fight back?
That's when we see partially compensated imbalances. The pH is still abnormal, so the problem isn't fully fixed, but now both the PaSO2 and the HCO3 are abnormal, working together to try to normalize that pH.
So in partially compensated respiratory acidosis, pH would still be low, the PaSO2 high, but now the HCO3 would also be high. Like the kidneys are saying, okay, we need to hold on to more bicarbonate to neutralize all this extra acid.
Exactly. It's like the body's saying, hey, we've got too much acid here, let's bring in some bicarbonate to balance things out.
And in partially compensated respiratory alkalosis, the pH would be high, PaSO2 low, and the HCO3 also low, as the kidneys try to get rid of that extra base.
You got it. Now, sometimes the body is a rock star and actually manages to completely normalize that pH, even though the underlying respiratory problem is still there. That's what we call fully compensated imbalances.
So fully compensated respiratory acidosis, for example, would have a normal pH, but you'd still see a high PaSO2 because of that respiratory issue, and a high HCO3, showing how the body has successfully compensated.
Perfect. Like the body's saying, okay, we've got this under control. We've balanced the pH, even though we're still dealing with that pesky CO2 problem.
This all starting to click now. You've really demystified those lab values.
Glad to hear it. Now that we've got the acid-base balance basics down, are you ready to tackle a specific respiratory condition we often see in critical care? How about asthma?
Let's do it. Asthma is a condition that affects so many people, and it can range from like mild to life-threatening.
Exactly. It can be really mild or it can be seriously life-threatening. You know, and asthma is a chronic inflammatory disease of the airways. So those airways, they get all inflamed and swollen, they produce too much mucus, and that makes it like really hard to breathe.
And it seems like those asthma attacks, those can be triggered by almost anything.
Oh, yeah, for sure. I mean, you've got common allergens like pollen, dust mites, pet dander, mold, even cockroaches.
Oh, yeah.
And then you've got irritants like smoke, air pollution, strong odors. Oh, and don't forget things like cold air, exercise, stress, and even some medications like aspirin and NSAIDs can trigger an attack.
Wow, that is a lot to keep track of. So let's say, a patient comes into the ER, they're having an asthma attack. What are some of the classic signs you'd see?
Well, think about what's happening in the airways, right? They're narrowed, then inflamed. It's hard to move air in and out. So you'll often see coughing, especially at night or like early in the morning. Wheezing, that's that high-pitched whistling sound.
Oh, yeah, you can't miss that.
Right, and that's the air struggling to get through those narrowed airways.
I've also heard some people only wheeze when they exercise.
Yeah, that's called exercise-induced bronchospasm. It happens because the airways get irritated and constrict during physical activity.
So besides coughing and wheezing, we might also see dyspnea. That's difficulty breathing, right?
Exactly. And their respiratory rate might be increased, because the body's trying to make up for that lack of airflow.
And if the asthma attack is really severe, the patient might even be using those accessory muscles, like in their neck and chest, to try to help them breathe.
Exactly. Trying to get every bit of air they can.
It sounds so scary. How do you actually measure, like objectively measure, how bad an asthma attack is?
That's where pulmonary function tests, PFTs, come in. These tests measure how well the lungs are working, how much air a person can inhale and exhale, and how quickly they can do it.
So PFTs are like a report card for the lungs.
Haha, yeah, that's a good way to put it. One of the key things we look at is FEV1. That stands for forced expiratory volume in 1 second. It basically tells us how much air the person can forcefully breathe out in 1 second.
So a lower FEV1, there's more airway obstruction.
Exactly. Another important one is FVC, or forced vital capacity. That's the total amount of air they can exhale after taking a really deep breath.
And what about PEF, peak expiratory flow?
Oh, that's a good one. PEF measures how fast a person can exhale. And patients can actually monitor this at home with a little device called a peak flow meter.
Oh, yeah. I remember learning about those. It's like a small handheld thing they blow into, helps them track their asthma and see if things are getting worse.
Exactly. It's really helpful for patients to be able to manage things themselves. Okay, so let's talk about how we actually manage asthma, with medications. As nursing students going into critical care, this is super important because you'll be working closely with doctors to administer and monitor these medications. So understanding the different classes and what they do is key.
I remember when I was first learning about all this, like the different inhalers and everything, it was so overwhelming. There are so many.
It can definitely seem like a lot at first, but the good news is they all basically fall into a few main categories. Let's start with bronchodilators. As the name suggests, these meds relax the muscles around the airways, which helps them open up.
So they're like tiny little muscle relaxers just for the lungs.
Uh-huh, exactly. And there are two main types of bronchodilators, short-acting beta agonists, or SABAs, and long-acting beta agonists, or LABAs.
Okay, so what's the difference between a SABA and a LABA?
So SABAs, like albuterol, think of those as the rescue inhalers. They provide quick relief from asthma symptoms, so they're usually used during an asthma attack or before exercise if someone has exercise-induced bronchospasm.
So like the 911 call for asthma.
Exactly. They kick in quickly, usually within minutes, but their effects wear off after a few hours.
Okay, and what about LABAs?
Labes like salmeterol and formoterol, those are more for long-term control of asthma. They're taken every day to help prevent those asthma attacks from happening in the first place.
So they're like the security system, always working in the background.
Right. Now, it's super important to remember that LABAs should always be used with an inhaled corticosteroid, never alone.
Why is that?
Well, LABAs are great at bronchodilation, but they don't do anything about that underlying inflammation in the airways. And if you leave that inflammation untreated, it can actually make the asthma worse over time.
Ah, that makes sense.
Mhm.
So corticosteroids, those are the ones that really tackle the root of the problem.
You got it. Corticosteroids, like butanide, fluticasone, mometasone, they work by reducing that inflammation in the airways. They're really like the cornerstone of asthma treatment, especially for moderate to severe cases.
So they're like the fire extinguisher, putting out the inflammatory fire in the lungs.
Perfect analogy. Now, corticosteroids can be delivered in a few ways: inhaled, oral, or intravenous. Inhaled ones are the most common for long-term control, while oral or intravenous are typically used for short bursts during, those asthma flare-ups.
And just like any medication, corticosteroids have potential side effects.
Oh, absolutely. Inhaled corticosteroids can cause oral thrush, which is a fungal infection in the mouth. So it's important to teach patients to rinse their mouths after using their inhaler. And long-term use of systemic corticosteroids can cause, things like weight gain, increased risk of infection, osteoporosis, mood swings.
Wow, there's a lot to keep track of. So, as nurses, we really need to be on top of monitoring for these side effects and making sure patients understand how to use their meds properly.
Absolutely. Holistic care, that's the key. Now, asthma is often diagnosed in childhood, but it can also develop later in life. And sometimes it gets confused with another chronic lung disease, COPD, chronic obstructive pulmonary disease.
Ah,
Oh.
COPD. That's another big one we see in critical care. But COPD, that's not fully reversible, right? Like asthma is.
That's right. COPD is a progressive disease that causes long-term damage to the lungs, which makes it harder and harder to breathe. It's mostly caused by smoking, but exposure to other irritants like air pollution or certain types of dust at work can also play a role.
Yeah, and I remember seeing COPD patients when I was in clinicals. They often have a very particular look, like they're constantly struggling to catch their breath.
You're right. COPD patients often have what we call a barrel chest, where the chest becomes rounded because of all the trapped air in the lungs. And they might have that pursed lip breathing, where they breathe out through pursed lips. It helps slow their breathing and keep those airways open.
Oh, and they can have club fingers too, right?
Exactly. Clubbing is a sign of chronic hypoxemia, low oxygen in the blood. Basically, the fingertips and toes gradually thicken and widen.
Wow, COPD really does a number on the body. So what's actually happening inside the lungs with COPD?
Well, there are two main components to COPD: emphysema and chronic bronchitis.
Okay, so let's break those down. What's going on with emphysema?
With emphysema, the tiny air sacs in the lungs, those alveoli, they get damaged and lose their elasticity. Imagine like a balloon that you keep blowing up and deflating over and over again. It eventually loses its ability to snap back to its original shape.
So the alveoli are like overstretched balloons that can't bounce back.
That's it. This makes it difficult to fully exhale, so air gets trapped in the lungs, which leads to hyperinflation.
And emphysema patients often have high CO2 levels in their blood because they aren't exhaling all of it effectively, right?
Right, they retain CO2, which can then lead to respiratory acidosis.
Okay, that makes sense. And what about chronic bronchitis? Where does that fit in?
Chronic bronchitis is all about the bronchial tubes, those airways that carry air to and from the lungs. With chronic bronchitis, these tubes get inflamed and swollen, and this leads to increased mucus production, that classic smoker's cough. The airways narrow, making it tough to breathe.
So whether it's emphysema or chronic bronchitis, the airflow in and out of the lungs is compromised.
Exactly. And over time, COPD can lead to a whole bunch of problems. Shortness of breath, wheezing, chest tightness, fatigue, frequent respiratory infections. It can even lead to right-sided heart failure.
Sounds like a vicious cycle. So how do we manage COPD? Is it similar to managing asthma?
There are some similarities, but there are also some key differences. We do use bronchodilators and inhaled corticosteroids for both, but the goals of treatment are different. With asthma, we're aiming for complete control of symptoms and preventing those exacerbations. But with COPD, the focus is more on slowing down the progression of the disease, managing the symptoms, and improving the patient's quality of life.
So it's more about harm reduction and support than a cure.
Exactly. Now, there are some nursing interventions that are super important for COPD patients.
Like what? What can we do to help these patients breathe easier?
Well, assessing their breathing patterns is a big one. We're looking for signs of respiratory distress, like tachypnea, which is rapid breathing, use of those accessory muscles, and cyanosis.
Cyanosis, that's the bluish discoloration of the skin and mucous membranes.
They got it. It happens because of low oxygen levels. And of course, we're closely monitoring their oxygen saturation levels.
Absolutely. But I remember learning that COPD patients often have lower normal oxygen saturation levels than people without COPD. Why is that?
Because their bodies have adapted to lower oxygen levels over time. So their target oxygen saturation might be somewhere between 88% and 92%, rather than the usual 95% or higher.
Wow, so we don't want to just crank up their oxygen to 100%.
Right. Over-oxygenating a COPD patient can actually suppress their drive to breathe, which obviously is not what we want. It can even lead to respiratory failure.
That's a crucial point. It's a good reminder that normal is relative, and we really need to individualize care for each patient.
Couldn't agree more. Another important intervention for COPD patients is teaching them breathing techniques, like pursed lip breathing and diaphragmatic breathing.
Oof, can you explain those a bit more? I remember learning about them, but a refresher never hurts.
Sure. Pursed lip breathing is kind of like blowing out candles on a birthday cake. The patient inhales slowly through their nose and then exhales slowly through pursed lips, like they're whistling. It helps slow down their breathing, keep their airways open longer, and prevent air trapping.
Okay, that makes sense. What about diaphragmatic breathing?
Diaphragmatic breathing helps strengthen the diaphragm, the main muscle we use for breathing. To do this, the patient either lies down or sits comfortably with their knees bent, and they put one hand on their chest and the other hand on their abdomen just below their ribcage.
And then they focus on breathing deeply into their belly, right?
Yep.
So that the hand on their abdomen rises as they inhale.
You got it. The hand on their chest should stay relatively still. This helps them maximize lung expansion and improve their breathing efficiency.
Those are great techniques. It's amazing how much of a difference something as simple as changing your breathing pattern can make.
It really can. Now, another big part of COPD care is managing that mucus production.
Oh yeah, that thick, sticky mucus. It's not the prettiest thing to see.
It can be challenging for sure. We encourage patients to drink plenty of fluids to help thin out that mucus. We might also use techniques like postural drainage and chest percussion to help loosen and mobilize those secretions.
Postural drainage. That sounds interesting. What is it?
Basically, we position the patient in different ways to use gravity to help drain the mucus from the lungs.
Oh, so it's like a natural way to help clear those airways.
Exactly. Okay, let's shift gears and talk about another respiratory condition that we see pretty often in critical care: pneumonia.
Oh, pneumonia. I actually have a story about that. You see, my crazy uncle, he once ran from the police down a river bluff.
He ran from the police. Wow, that's intense. What happened?
He always had a knack for getting into trouble, bless his heart. Anyway, he was trying to escape, tripped, and fell, hit his throat on a rock. He ended up aspirating some water and, yeah, developed pneumonia.
Wow, that's quite a dramatic way to get pneumonia. Aspiration, that's when things like food, liquid, or vomit get into the lungs. And it's a common cause of pneumonia, especially in older adults and people who have difficulty swallowing.
Yeah, he was in the hospital for a while, but thankfully made a full recovery. It's a good reminder, though, that pneumonia is serious business, and it can happen to anyone.
Absolutely. It's an infection of the lungs, and it can range from mild to, life-threatening.
So what causes pneumonia?
Lots of things, really. It can be bacteria, viruses, fungi.
Okay, and how do these germs actually get into the lungs?
They can be inhaled, spread through the bloodstream, or, like in your uncle's case, aspirated. And we classify pneumonia in a few different ways, depending on where it's acquired.
Oh, right, like community-acquired pneumonia versus hospital-acquired pneumonia.
Exactly. Community-acquired pneumonia, or CAP, that's the most common type. It's usually picked up out in the community, from everyday interactions. Hospital-acquired pneumonia, or HAP, that develops more than 48 hours after someone's been admitted to the hospital, and it's often caused by more resistant bacteria.
So HAP is more of a concern because those hospital bugs can be harder to treat.
Exactly. And then you've got healthcare-associated pneumonia, or HCAP. It's kind of a hybrid, It develops in people who have had recent contact with the healthcare system, like those in nursing homes or receiving dialysis.
And then finally, there's ventilator-associated pneumonia, or VAP, right?
You got it. VAP is a type of pneumonia that develops in patients who are on a ventilator.
And that one's a big concern, right? Because those patients are already pretty vulnerable.
Absolutely. VAP is a serious complication of mechanical ventilation because, again, it often involves those resistant bacteria.
So as nurses, we need to be super careful about preventing VAP in our ventilated patients.
For sure. We'll talk more about those interventions later. But for now, let's switch gears and talk about some conditions that are particularly relevant to infants and children: infantile apnea and SIDs.
Oh, those are two conditions that, like, every nursing student, especially those working with pediatrics, need to understand.
Absolutely. Let's start with infantile apnea. It's important to reassure parents that brief periods of apnea, like 5 to 10 seconds, are actually totally normal in infants under 6 months of age. Their respiratory systems are still developing, and those little pauses are usually nothing to worry about.
So it's like their brains are still learning how to regulate their breathing.
Exactly. But when those pauses are longer than 20 seconds, or they happen with other concerning symptoms like bradycardia, cyanosis, or hypotonia, well, then it's considered infantile apnea, and it could be a sign of something else going on.
So what kind of problems can cause infantile apnea?
Prematurity is a big one. Premature babies, their respiratory systems aren't fully developed, so they're more prone to apnea. Other causes can include central nervous system issues, trauma, bronchitis, GERD, and feeding difficulties.
So we need to watch for those risk factors and make sure we're teaching families what's normal and what's not when it comes to those little baby breathing patterns.
Absolutely. And it's also super important to be aware of SIDS, or sudden infant death syndrome. That's the sudden death of a seemingly healthy infant under a year old.
SIDS is such a heartbreaking condition. It's something every parent worries about.
It really is. And although the exact cause of SIDs is still unknown, there are things we can do to reduce the risk.
Oh, like what?
Creating a safe sleep environment is key. We recommend that babies sleep on their backs on a firm surface and without any loose blankets, pillows, or toys in the crib. We also advise against smoking around infants and encourage breastfeeding, which has actually been shown to reduce the risk of SIDS.
So it's all about minimizing those risk factors and making the sleep environment as safe as possible.
Exactly. And if a family does experience the tragedy of losing an infant to SIDs, it's important for us as nurses to be sensitive and compassionate.
For sure. We need to avoid placing any blame or making them feel guilty. It's about offering support, understanding, and resources to help them through such a difficult time.
You're absolutely right. We might suggest things like home visits from a SID specialist, support groups, counseling services. It's also important to explain that an autopsy might be necessary to determine the cause of death. Sometimes that can provide some closure for the family.
So it's about offering support, resources, and understanding during an incredibly difficult time.
Exactly. Now let's move on to a condition that affects both adults and children: obstructive sleep apnea, or OSA.
Oh, sleep apnea. I once had a roommate who snored so loudly it sounded like a chainsaw. Turned out it was sleep apnea, not just bad manners.
I can imagine. So OSA is characterized by these repeated episodes where the upper airway gets completely or partially blocked during sleep. It causes pauses in breathing that last at least 10 seconds, and they happen at least 5 times every hour.
So it's not just snoring, it's actually stopping breathing while you sleep.
Exactly. And these pauses can have some pretty serious consequences because they disrupt sleep, they reduce the oxygen levels in the blood, and they can even lead to long-term health problems.
Like what kind of problems?
OSA is linked to an increased risk of hypertension, stroke, diabetes, and cardiovascular disease.
Wow, that's definitely not something to take lightly.
Wow.
What are some of the risk factors for OSA?
Obesity is a major one. Extra weight, especially around the neck, can put pressure on the airway, making it more likely to collapse during sleep. Other risk factors include congenital defects in the oral cavity, a short or large neck circumference, and smoking.
So as nurses, we need to be aware of these risk factors and be on the lookout. What are some things that might make us suspect OSA in a patient?
Things like daytime sleepiness, morning headaches, snoring, disturbed sleep patterns, and an increased neck circumference. These are all red flags. And of course, if a patient reports snoring, we need to take that seriously, even in kids.
You're right. Snoring isn't always harmless. It can definitely be a sign of something more serious. How is OSA diagnosed?
The gold standard is a sleep study called polysomnography. It involves monitoring a whole bunch of things while the patient sleeps: brain waves, eye movements, muscle activity, heart rate, breathing patterns, and blood oxygen levels.
So it's like a full overnight assessment of everything that's going on while they're sleeping.
Exactly. And it gives us a lot of information about how severe the OSA is and what the best treatment options might be.
Okay, so what are some of those treatment options?
One option is an oropharyngeal positioning device. It's basically a mouthpiece that helps keep the airway open while they sleep. Another common therapy is continuous positive airway pressure, or CPAP.
Oh, CPAP. That's the mask people wear over their nose and mouth while they sleep.
That's
Yeah.
it. CPAP delivers a continuous stream of air, which helps keep the airway open and prevents those breathing pauses. It's really effective, but it does take some getting used to.
I imagine compliance can be an issue with CPAP. It can't be very comfortable with a mask strapped to your face.
It's true. That's why patient education and support are so crucial. We need to explain why CPAP therapy is so important and help them find a mask that fits comfortably and is easy to use. We also have to emphasize the importance of keeping the equipment clean to prevent infections.
Right, so we're not just giving them the machine and saying, good luck. It's about ongoing support and guidance.
Exactly. And in some cases, surgery might be an option. This is usually to correct structural abnormalities that are contributing to the OSA, like a deviated septum or enlarged tonsils.
So there are a range of treatment options depending on how severe the OSA is and the needs of the individual patient.
Exactly. And as nurses, it's important that we can assess for OSA, educate patients about it, and provide that ongoing support to help them manage their condition.
Makes sense. And finally, let's talk about a condition that's a global health concern: tuberculosis, or TB.
TB is caused by a bacterium called Mycobacterium tuberculosis, and it primarily affects the lungs, although it can spread to other parts of the body.
And while TB is declining in North America, it's still a major cause of death worldwide.
That's right. More than 1 million people die from TB every year, mostly in less affluent countries that don't have the same access to healthcare.
It's a disease that really affects those who are already vulnerable.
Unfortunately, yes. It's more common in certain populations, like those living in crowded conditions, homeless individuals, the elderly, people who use injection drugs or alcohol, those with lower socioeconomic status, foreign immigrants, and people with compromised immune systems.
So it's a complex issue with a lot of social and economic factors at play.
Absolutely. And it's important to understand that not everyone infected with TB actually develops the active disease.
What do you mean?
Only about 5 to 10% of people infected with TB will actually develop active TB disease.
So what happens to the other 90 to 95% of people?
They have what we call latent TB infection. This means they have the bacteria in their body, but their immune system has it under control. It's walled it off, so to speak, so it's not causing any illness. They'll test positive on a TB skin test, but they won't have any symptoms and they're not contagious. However, that dormant infection can reactivate later in life, especially if their immune system weakens.
So it's kind of like a ticking time bomb.
In a way, yes. And that's why it's so important to identify and treat latent TB, especially in people who are at high risk of reactivation, like those with HIV or other conditions that weaken the immune system.
Okay, so how do you treat latent TB?
The usual treatment is a daily dose of isoniazid for 9 months. It's a long course of treatment, but it's very effective in preventing that infection from becoming active.
So lots of education about medication adherence for TB, both latent and active.
Absolutely. Now, for active TB, the treatment is more intensive. It involves a combination of 4 drugs: isoniazid, rifampin, ethambutol, and pyrazinamide, taken for at least 6 months.
Wow, that's a lot of medication.
Yeah.
I imagine there are some side effects to watch out for.
Yes, definitely. These medications can be tough on the liver, so we need to monitor liver function closely. They can also cause gastrointestinal upset.
Hmm.
And rifampin, as I mentioned earlier, it can actually turn body fluids orange.
Oh, yeah, orange urine, orange tears. Definitely something to warn patients about. So patient education is super important when it comes to TB management.
Absolutely. We need to make sure patients understand how important it is to take their medications exactly as prescribed for the full duration of treatment, even if they start feeling better. We also need to teach them about the signs and symptoms of side effects, when they need to seek medical attention.
And we need to really emphasize those infection control measures, right?
Yes.
Because active TB is contagious.
Absolutely. Patients with active TB need to be isolated in a negative pressure room to prevent the spread of those bacteria. They also need to wear a surgical mask whenever they're outside of their room to minimize the risk of infecting others.
So there are a lot of precautions to take to prevent the spread of TB, both in the hospital and in the community.
Exactly. And it's important to remember that TB is a global issue that requires a multifaceted approach. That means public health initiatives, access to healthcare, and ongoing research to develop new and better treatments.
Well said. We've covered a lot of ground today, from the basics of the respiratory system to some really complex and serious respiratory conditions.
It's been quite a deep dive.
It has. I hope our listeners, especially those future nurses out there, feel a little more prepared to tackle the challenges of respiratory care.
Me too. Remember, critical care nursing is all about thinking critically, acting quickly, and advocating for your patients.
And never stop learning. There's always something new to discover in the world of medicine.
So true. Keep those brains engaged, those stethoscopes handy, and those hearts compassionate.
And on that note, we'll sign off for today. Thanks for joining us on the Deep Dive.
Until next time, stay curious and stay well.
Yeah, it's crazy to think that a tiny little bacteria can cause such huge problems worldwide. It really shows you how important those public health measures are, and working together globally to fight these infectious diseases.
Absolutely. And speaking of working together, nurses are such a crucial part of the team when it comes to TB care. We work so closely with doctors, respiratory therapists, pharmacists, social workers. It's all about making sure our patients get the best possible care, that it's comprehensive and everyone's on the same page.
So it's not just about giving meds, it's about being a detective, an educator, an advocate, a coordinator, all rolled into one. Sounds like a tough job, but also really rewarding.
It definitely is. Now, before we wrap up this deep dive into respiratory conditions, I want to circle back to something you mentioned earlier, those nursing interventions for pneumonia patients. What are some key things we can do as nurses to really help these patients recover?
Right, good point. Let's see, we talked about oxygen therapy, right, to make sure those oxygen levels stay up. And encouraging coughing and deep breathing to help clear out the airways.
Exactly. And what about incentive spirometry? That's a really simple but effective tool to encourage patients to take those nice deep breaths and prevent atelectasis, which is when those tiny air sacs in the lungs collapse.
Ah, yeah, the incentive spirometer. I remember using that in clinicals. It's like a little game almost. The patient breathes in deep and tries to raise that little ball as high as they can.
Right, and it helps improve lung function, prevent complications. Now, what about hydration? Why is that so important for pneumonia patients?
Well, staying hydrated helps thin the mucus, which makes it easier to cough up. And, it helps prevent dehydration, which can be a problem, especially when patients have a fever and their respiratory rate is up.
Great points. We want to encourage our patients to drink plenty of fluids, water, juice, even broth. And speaking of broth, remember my crazy uncle who aspirated on water. It's a good reminder about how important it is to check for any swallowing difficulties and take precautions to prevent aspiration in those patients who are at risk.
Absolutely. We might need to adjust their diet, thicken liquids, or even think about a feeding tube if they're having a lot of trouble swallowing.
And always, always elevate the head of the bed, especially during and after meals, to help minimize that risk of aspiration.
So many little things we can do as nurses that make a big difference.
And it's not just the physical care, it's the emotional support too. Pneumonia can be really scary and debilitating, so it's important to be patient, understanding, and encouraging.
And remember, folks, good hand hygiene goes a long way in preventing the spread of those respiratory infections like pneumonia. Wash those hands like you just finished dissecting a frog in anatomy lab.
Haha, great visual. Okay, before we wrap up for today, I want to leave our listeners with something to think about. Imagine you're a brand new critical care nurse, fresh out of school, and you're taking care of a patient who suddenly develops shortness of breath. What are the first 3 things you would do and why?
Ooh, That's a good one.
Hmm.
Really makes you think on your feet and apply everything we've talked about.
Exactly. Keep those brains working, future nurses.
And remember, every breath matters. Your role as a critical care nurse is to be a guardian of those breaths, advocating for your patients and making sure they get the very best care.
It's a tough journey, but it's so incredibly rewarding.
Well said. And on that note, we'll wrap up this deep dive into the world of respiratory care. Thanks for joining us on the deep dive.
Until next time, stay curious, stay informed, and never stop learning.